Well, welcome, Dr. Geyer. It's so good to see you again. Glad you're here with us today. Last time we talked, we were reviewing the importance of opioid stewardship, such an important topic. But we really had focused on how the COVID pandemic had contributed to not only a 30% increase in drug overdoses compared to the prior year, but the highest opioid overdose rate in American history. That's pretty unbelievable. The numbers are just staggering. So, in this episode today, let's talk about how to get started on building an opioid stewardship program, including forming the initial team, getting that really important leadership engagement, and really what to address in those first critical meetings. So, let's just jump right in, Holly. This is such important information, and I'm so excited to hear what you have to share with our audience today.
Thanks, Marie. Absolutely. In short, Mayo Clinic didn't have one. Like many organizations around that 2015 timeframe, we were following the growing conversations about the rising opioid overdose rates and concerns with overprescribing. But one of the biggest problems that we were facing in the medical field is that best practices for safe opioid prescribing were simply not standardized. There were lots of varying opinions out there in the medical literature. Some societies had put out what they had proposed to be a good approach for cutting back on prescribing, regulating how we're prescribing. But keep in mind that the medical field was still facing tremendous pressure from the evolution of that national pain is the fifth vital sign campaign that was circulating. And regulatory agencies were still emphasizing the need to control a patient's pain to their satisfaction, as well as compromising this could lead to a host of other issues for providers and institutions, a road that we didn't want to go down. Negative patient satisfaction scores, reduced reimbursement, poor reputation, and all these other issues. So, patient litigation was also another concern. It was claiming uncontrolled symptom management as a reason that they could go after providers and gain financial gain. So, there were many threats out there that essentially allowed patients to essentially self guide their analgesic regimens. It wasn't until I would say around 2016 when the CDC started to release their guidelines for management of opioids in chronic pain populations. That was a comprehensive summary of all the problems out there and evidence-based solutions that was first time made available to providers to start practicing based on national guidelines and evidence-based solution. Truly, it was like turning on a floodlight when you've been working in the dark with nothing more than lightning bugs giving you direction so far. It was revolutionary for us. And so I would say it was probably that combination of these guidelines and then ultimately a release of new Arizona state laws that were requiring that we check our prescription drug monitoring programs. That's also known as the PDMP when we prescribe opioids. And then good insight on the part of our leadership, I would say, that pulled together the first team addressing opioid stewardship in 2016. I personally had some experience working on our state medical association legislative committee, and I was also working on my addiction medicine subspecialty at the time. And so that's why hospital leadership had approached me to take this on as a side project. I'll be honest, I could have never imagined it would turn into a career.
Yeah, that's really insightful. I know that when we work in quality, we think about structure, process, and outcome, right? Structure, meaning you have to have all of the right pieces in place. You have to have the right people involved. You have to have the right tools and resources, right? And then you build on that. You have the right processes in place. And that really gets you to the right outcomes. So, one of the things I think we notice when we look at structure, process, and outcome is that sometimes we don't always have the right things in place that we're measuring. And so, I think you've talked a little bit about some of the impact that processes and guidelines had, and maybe didn't end up revising or changing things the way we wanted them to. So, that's really important. So once administration or the leaders of your organization kind of approached you and said, let's do this, or Dr. Geyer, you do this, or what was that conversation kind of like in what the request was, what they wanted you to do, what their guidance or direction was? Tell us a little bit about that, because I think that's a really important piece and conversation for the field to hear about.
Absolutely, Marie. I can tell you it's really hard to know where you're going when you don't know where you are. And that was precisely the position I found myself in as we started to pull together our first meeting to take a look at this epidemic. I had followed it from the periphery, and I'll tell you that the short sighted part of me truly thought beforehand that the solution would be an easy communication piece to the practice to tell our providers to stop prescribing as many opioids as they were and send everybody with addiction symptoms to a treatment program. I don't think I could have been more ignorant. Unfortunately, leadership had much better insight. For our kickoff meeting, they included these representatives from multiple prescribing fields, so lots of buy in. We had pain management, we had primary care, we had surgeons and hospitalists, addiction medicine subspecialists, and emergency medicine. And then they brought in the pharmacists and nursing staff and social work, government relations and legal compliance. We had IT, we had quality, and then importantly, we had some high ranking members of administration. And for this first meeting, we sat there and we listened to the extent of concerns with opioid prescribing from all these different perspectives. It was like drinking from Old Faithful. There were so many facets to this epidemic that I personally had not considered. Just to give you some examples, what do current prescribing practices look like in-house anyway? How often are we following these new CDC guidelines? Can we spell CDC around here? I mean, and these are brand new. Have they been implemented by specific practices? How do we tailor and then standardize these guidelines to every area of the practice, like the ER versus outpatient versus inpatient versus non-surgical versus surgical settings? My goodness. How are we going to monitor compliance, right? Can the EMR give us the numbers we think we need? How are we going to educate providers on the prescribing problems and then ultimately the solutions? And here's a scary question: how are patients going to take these changes? What tools do we have to even educate them? And how are we going to keep them satisfied despite the fact we're looking at using fewer opioids? How do we keep up with the state laws that keep evolving? And how do we ultimately have input on the content if we don't necessarily agree with what's coming out? How are we going to manage patients with evidence of opioid use disorder? Do we already have protocols and workflows in place for this? As you can imagine, just a host of other questions. This is the tip of the iceberg. The potential to do this that came out of solving all these issues as we laid them out on the table for that first 1 hour meeting, honestly, I thought it would take a millennium to fix. It was so clear that building an opioid stewardship program from the ground up was going to take a village. So, without any real blueprints to guide us through the process, we dove in and we took the first steps of dividing and conquering.
That's so important. I think that whole idea of the multidisciplinary team, which in some cases complicates it, right? Because as you described, there's so many people involved, right? So many people, so many thoughts, so many opinions. But it really is important. It's important from the perspective of engagement and how do you get buy-in with an organization and to have people from the top committed and involved and then flowing all through the processes that occur, those that are doing the work, right? So many times we don't get those frontline folks involved. And really, those are the people who know what works, they know what's going on. And it's so important to have those folks. You mentioned the patient or the customer, the people that we're caring for in the organization. One of the things that people are doing is having the voice of the customer actually on the committee doing the work. Did you have anybody, or did you have some conversations around whether or not to include someone actually who is experienced this problem or to give their actual input around their experience?
Absolutely. Not only did we have some smaller subgroups that were formed that we surveyed based on some of the changes that had taken place, but in addition, Mayo Clinic has always been engaged in research. It's one of our three shield practices. And some research studies had come out that identified that despite making broad scale changes in prescribing practices, particularly amongst our surgical colleagues, patients remained satisfied. We were giving away too many opioids. And when we figured out how to scale that back to what patients actually used and needed, they were equally as, I should say, happy, impressed with the care that was delivered as when we were overprescribing.
That's so important. It really is important to have the voice of the patient or the voice of the customer present and part of the work we're doing. And I think sometimes we hesitate to do that, but it really does get at the crux of the issue. If you haven't been through an experience yourself, we assume we know, we think we know, but really to have that voice present is so important. And especially when you're talking about controlling pain. There's so many elements right into pain and the experience that someone has in pain, what pain means to someone, right? It's very different what one person interprets as pain versus what someone else does. I had that experience with a family member who had a terrible fall and was, very injured and you would think was in a lot of pain. And we said, are you in pain? They said, no, I'm a little sore. But that person's perspective on pain was so different than what other people define pain as. So I think understanding those issues are just so important. Let's go back for a minute to talk a little bit about the key administrators, the roles, those leaders that really participated in this. Can you talk a little bit about what the role was for, I'm assuming either a CEO or one of the organization leaders? Can you talk a little bit about what the role was that they played so that other people can get some example? Sometimes we think that the CEOs either don't have time, don't want to participate in these things. Talk a little bit about what that role was.
Yeah, great question. Practice changes this monumental really needed leadership buy in. And we needed someone at the top to advocate for our efforts on multiple levels. We needed our committee to have a voice to those that were controlling practice change. We needed them for communication and we needed them for funding. Having an advocate in leadership proved invaluable for us as we moved all of these sub projects that came out of this working group forward. Leadership got us to the right committees, they got us the necessary finances, and they moved what I would describe as rather immovable barriers, shall we say? Individuals that were less than enthusiastic to see prescribing changes occur in the practice. We were able to intervene because of their support when metrics weren't being met as well. There were some providers that were not interested in standardizing the degree that we had recommended based on guidelines, and it took leadership to really move the dial for some of those people who were just very ingrained in their practice approach thus far. So we appreciated leadership from beginning to end of this process. I don't believe we could have built a program without administrative support.
I think that's such a good point. And really, Holly, it seems to me, and you can correct me if I'm wrong, but what we're really talking about is significant culture change at so many levels in the organization. And when you are talking about culture change, it is really important for the leaders to participate. We're not just changing a process, you're changing a lot of processes in an organization. You're also changing the way people think about those processes. Can you tell me whether the board was involved at all? I think sometimes, that's another place people think about or forget to think about. And did you have any board involvement?
That's a great question, Marie. I am very familiar with the board being aware of Mayo Clinic having some culture changes related to opioids. To the degree that they had decision making capacity on this topic, I'm not sure. I do know that all of these decisions came from a very top down format from leadership, all the way up to our head CEOs at each of the campuses. So there was very high level buy in nonetheless.
Absolutely, and so important. I think that most of the time, many of the times, the board is informed and they're on board. They're on board. The board is on board of the change in the organization, especially when the CEOs or the leaders of the organization are involved. But I think that's also another place that organizations can think about. And very often you find really great support from the board members for these kinds of things, especially when they involve culture change. Some of the board members are in the community and see these experiences from another perspective. So I would just encourage our audience to think about that. Don't exclude the board, but think about how that might be facilitating. And as you mentioned, Holly, so much of this is about moving barriers, right? And having the right people on board that can help you move the barriers that you identify and that you need moved really is important. And that's a significant role for the leadership. Great information. You mentioned funding. You mentioned that piece of this. How was that addressed? Did your CFO participate by any chance? That's another area that sometimes we leave out. As a nurse leader in an organization, I had the motto of saying finance was always my friend because I know my weaknesses are in the finance area. So I always look to make finance a strength, a strong partner that would be there with me and help out. But what role did finance play in this work that you did?
Excellent question. CFO is a position I was not closely engaged with throughout this process, but we had buy-in from other levels. We had CEO and we had CAO, and from there, all finances followed suit. So I will say they were engaged, but not necessarily directly. And you're absolutely right, Marie. If you're not getting the direction you need from the higher levels, a CFO would be a position definitely to approach. When it comes to financing management of an epidemic, absolutely, there's going to be some costs involved. I'm pleased to say that leadership made it easy on us. It was already a prominent enough issue in the media to give kind of a baseline understanding that this is important to Mayo Clinic. And as you can imagine, the word epidemic never sits well in healthcare. We did have to sell this, I will say that, to leadership. I'm talking CAO, CEO, and other key figures. So we needed to do our homework. We started off by using the EMR to obtain really baseline metrics of what our institution was already doing. You know, the number of prescriptions we were writing, total dosages in each prescription, number of refills, and PDMP checks by specialties. And then we use these numbers to really compare them to the averages of what the CDC was recommending to get an estimate of just how far we were out of compliance. And with that data in hand, then we took that back to the literature and said, okay, well, we've got CDC guidance. What do subspecialties have to say about these practices? Are there already, best practice guidelines on how much you give for some urologic procedure or vertebroplasty? And after this, we built a roadmap as to what ideal state would look like so we could ultimately ask for that funding. We presented that data to leadership, along with the next steps and the extent of resources that we would need to solve the problem. And throughout the conversation, I would say this is key. We emphasize the existence of guidelines, of regulatory recommendations that are already in existence, of state laws, and used all of that to really drive home the why. I could say that because of this, we had broad support for our efforts, and it came in the form, number one, of protected time. For people working in the healthcare field, they know that that's not a small cost. Many of our members serving on these subcommittees had up to 10% time to dedicate to this topic. They also gave us finances in the form of system engineering and support. These are engineers that specialize in building the workflows and the protocols, the patient education material, all of these elements that actually turn a concept into life. And then they were willing to partner with us in practice communication strategies. They advocated using institutional voice at a state level. They played quarterback when we ran into areas of the practice that weren't necessarily making changes. And then at an enterprise level, they did provide us the funding necessary to make all of this possible outside of just the category time. So it was a great teamwork effort, and we so appreciated administration and leadership's support.
Holly, you just hit on a couple of things that are so important in whether or not these kinds of efforts can be successful. And that one is, in order to have people participate, is really acknowledging and making room for their time to participate in this. So often we forget to think about that. We culturally are so used to just piling on additional work and just figuring we're going to fit it in somewhere and get it all done. But there's that point where that just doesn't keep working. So really making space for that work and for the time for that is really important. The other thing you mentioned that I think is so important and really helpful is that idea of the system engineers. I worked in my past with a lot of management engineers, process engineers to help us with these kinds of things and help us with our quality improvement efforts within our organization. And those folks are so valuable. They really can help you with time studies and look at where the rework occurs in your processes and your redundancy and all of those pieces. So kudos to your organization for pulling those folks in as well. That's really a great thing to hear. As things went on and as this work continued, did the committee change? Did your team change as things evolved? Did you see any of that?
Really good question. Over about a year-long period, we saw this project turn into a program. And I will say it didn't start that way. That was not our intention. We thought we'd have a one-time and done approach to this, but it really did morph into something that needed longitudinal care and management. And so once we built this infrastructure, and again, that took a good year, we started networking with our colleagues at the other campuses. Keep in mind, we had Florida, we had Rochester, all of which had their own state laws and guidelines to deal with. And from that, we morphed into more of an enterprise or multi-site stewardship program. This program now represents the enterprise views on the topic of opioid stewardship and has enterprise representation from each site, which is so key. We meet on a regular basis every 2 weeks for our enterprise group, and then every month for our local group to individually monitor exactly what's happening, how are we following trends, what's changing in the literature, what new laws have come out, what questions are being fielded from our campuses, and what new topics we need to address. We are able to bring in the content experts that we had from that original group as needed, but we don't invite them to all of these meetings. As you can imagine, time is in limited quantity, and as various issues creep up, we do have the benefit of reaching back out to them as needed. We've also had the benefit of being housed under the quality program at Mayo Clinic, and this allows us to stay in pretty regular communication with leadership about where we see practice improvement efforts or when we need additional funding for a project.
Well, of course, Helly, as a quality improvement person, it makes my heart happy to hear that this is under quality improvement or performance improvement, whatever your organization calls that. But it's awesome to have this in there. So, just really one last question from me, and that is this a priority in your organization's strategic plan, either at the enterprise level or at individual hospital and health systems?
Marie, that's a great question. Mayo Clinic has kept its strategic plan at a very high level. And although opioid stewardship in itself is not necessarily on that strategic plan as a line by line effort, it's housed under quality. And quality is always a top priority at Mayo. And so, much like management of catheter related infections and bloodstream infections and all these other metrics that we're monitored for, we put opioid stewardship under that priority list. And of course, as the field evolves, we'll continue to monitor how we're doing as an institution. If we're not making the metrics that we want to see, if we're lagging behind national statistics, or if overdose rates continue to go up and we're simply not having the effect we want, that could certainly change from a strategic plan perspective.
Holly, I really love that because that says to me that quality is such a priority for the organization. And this is right there with all of the other things that impact the way our patients and their families experience their own health improvement journey. So that's really important to hear. So that's a great behind the scenes view at the committee that you created and the process that your organization went through in order to begin the opioid stewardship program, and including putting that committee together. Do you have any final thoughts or last minute pearls of wisdom that you'd like to include for our members who might be thinking about going on the same journey or already started on that journey, lessons learned, anything last that you would like to share?
Oh, wow, Maria. I could go on for a year talking about this topic because there's so many elements to it. But if I had the opportunity to highlight just one thing, I would say this. I'm offering my perspective from where I work, and that's a large academic, multi-site medical field perspective. And what I don't want to do is give the impression to our audience that you need to be at that level of grandiosity or size in order to integrate opioid stewardship. I know many of our listeners are a total of two prescribers in their practice, right? And that's okay. In fact, that might make your workload to get a program going much easier. I believe in the next couple of podcasts, we're going to be talking about the tools that a practice of any size is going to want in place to help prescribe safely. And so I ask our audience, stick with us. We want to prepare you for what you need. So stay tuned.
Holly, thank you. That's awesome. We know that change happens in an organization from the top down, from the bottom up, and right in the middle. So it happens anywhere in an organization, and I think your story reflects that. I was just at a conference doing a presentation, and at the end of a presentation, a frontline caregiver that was in the audience jumped up and said, "I can do this." And it was just the perfect ending to a conversation around who starts change in an organization. So that's a great message for our listeners that it can start anywhere and it can start all those places or just one of those places. Holly, thank you so much for sharing your story with me and with the audience. And as you said, I hope everybody comes back and we really look forward to continuing the conversation and sharing all of the experiences and the best practices you and your organization have achieved. So thank you so much.
Absolutely, Marie, and thank you.